Welcome to this series of lectures in oral medicine, this one titled Oral Epithelial Dysplasia. Firstly, let's look at some terms. Leukoplakia or white plaque and erythroplakia or red plaque are the most common precursor lesions of oral squamous cell carcinoma. The histopathological term epithelial dysplasia is applied when there is a disturbance of architecture and cellular atypia in the squamous epithelium. Presence of epithelial dysplasia is one of the prognostic features of malignant transformation of pre-malignant, precancerous or potentially malignant lesions. However, it should be noted that non-dysplastic lesions may become malignant, as well as not all dysplastic lesions become malignant. So definition of white patch has undergone change over the years. In 1978, WHO defined it as a white patch or plaque that cannot be characterized clinically or histopathologically as any other disease. In 1994, this was changed to a predominantly white lesion of the oral mucosa which cannot be characterized as any other definable lesion. Some oral leukoplakias will transform into cancer. Then in 2007, the term leukoplakia should be used to recognize white plaques of questionable risk, having excluded other known diseases or disorders that carry no risk of cancer. So the term leukoplakia is really a clinical term with no histological connotation. A precancerous lesion in past terms was one that morphologically altered tissue in which cancer is more likely to occur than its apparently normal counterpart, as of 1972 WHO definition. Precancerous condition is a generalized state with a significantly increased risk of cancer. Etiological agents for oral cancer include tobacco, alcohol, candidosis, possible viral infections with human herpes simplex virus and HPV 18 and 16 strains, sunlight, especially of the cancer of the vermilion border. So the previous terms, the precancerous lesion indicated that the cancer arises at the site of a lesion, and precancerous condition is a cancer arising in any site of a person with that condition. So a better term to use instead of precancerous lesion or condition is a potentially malignant disorder. So potentially malignant disorder that indicates the possibility that the lesion, such as leukoplakia or malignancy, may arise elsewhere as a result of field change. So what we're saying is that in a person that has the potential to undergo malignant change, there is changes in the cellular architecture in most areas. So the most common potential malignant disorders or PODs are leukoplakia and erythroplakia as defined previously. And the gold standard for assessment of POD is by microscopic evaluation through hematoxylin and eosin staining to look for the presence of epithelial dysplasia. However, it must be noted that this can be subjective due to either intra or inter-observer variations. 36% of dysplastic lesions and 16% of non-dysplastic leukoplakia progress to carcinoma. Severe dysplasia has 16% transformation. Severe dysplasia is dysplasia occurring in the full thickness of the epithelial layer. 50% of biopsy clinical leukoplakias show epithelial dysplasia, and not all these lesions progress to carcinoma. So we can't just say that it's a linear progression. Sometimes these dysplastic lesions can turn into carcinoma, others can regress or spontaneously resolve. 50% of severe and 30% of moderate and less than 5% of mild dysplasia are thought to progress to cancer. So what are the types of white patches? You've got the homogeneous plaque, which is basically an area of mainly white. It's not raised, it's just uniform in appearance. Nodular, which could indicate that they are areas of um, slightly raised, like a nodule. Nodular plakia on the left buccal mucosa extending posteriorly from the commissure. Note the small nodules yellow in where the yellow arrows are on an erythematous base, so red base. You got this white nodule on a red base. Verrucous, which means basically frond-like, and it's exophytic in areas. Subtypes, again, better to think in terms of homogeneous or erythroleukoplakia, which generally tend to have high risk of malignant change. Then there's a condition called proliferative verrucous leukoplakia, or PVL, where you get these verrucous leukoplakias occurring in one site, and they will progress to other sites and so on, and sometimes the whole mouth may be covered with these white plaques. And the interesting thing about PVL is that if you biopsy different areas, you will see areas that are non-dysplastic, some areas that are mild, moderate, and some areas that are have undergone malignant change. And it's very difficult to know which site, when the whole mouth is involved, which site to actually biopsy. Bowen's disease is defined as an intraepithelial carcinoma in situ, that is dysplasia that occurs in the full thickness of the epithelium. So in this patient we've got leukoplakia on the right side, which is not histopathologically doesn't show any dysplasia, and on the left side there is carcinoma in situ. So if you look at the lesion histopathologically, what you see is a thickened keratin layer with the underlying connective tissue, which may show changes that are deemed to be dysplastic. Van der Waal and others created this flow diagram for clinical diagnosis of leukoplakia, and if you follow this from a clinical point of view, it can give you some an aid to how you can manage someone that comes in to see you with a white lesion. Alternatively, I have also provided in one of my articles another diagram, and this is also available on the website oralmednet.net or oralmednet.com, and if you log on to that and register for free, you will get much more oral medicine clinical notes and resources for your not only just for the clinical use but also for your exams and study. So Wanakulasuri et al. On 2007 indicated that these are the disorders that need exclusion to arrive at a diagnosis of leukoplakia. So the white sponge nevus, frictional keratosis, and so on down the list. Even skin grafts can give the appearance of a white wrinkled surface. So the diagnostic features of these disorders are mentioned in this diagram, and where whether or not biopsy is indicated is also present there. So in basically palatal lesions in reverse smoking, smokers that light the smoking the lit end of a cigar, cigarette, or inside the mouth, and it can lead to red or white or mixed lesions of the palate. Oral submucous fibrosis, OSF, is a chronic disorder characterized by fibrosis of the lining of mucosa of the oral cavity and the upper digestive tract. Fibrosis of the lamina propria. Early signs may have burning sensation, blanching of the mucosa, and leathery mucosa. Late signs may show fibrous bands within mucosa, limited mouth opening, woody changes of the mucosa and tongue. Other lesions to exclude: oral lichen planus, discoid lupus erythematosus, and hereditary disorders such as dyskeratosis congenita and epidermolysis bullosa, which has been covered in previous lectures. Erythroplakia, the definition is a bright red velvety plaque or patch that cannot be characterized clinically or pathologically as being due to any other condition. Erythroplakia, especially in the floor of the mouth, ventral tongue, soft palate, and anterior pilus of the tonsils, exhibit a high frequency of malignant and pre-malignant change. Differential diagnosis of erythroplakia may include erythematous candidosis, mechanical irritation, denture-stomatitis, vascular lesion, and non-specific inflammatory lesions. So Reichardt et al. Indicated that a condition, inflammatory or immune disorders, diagnostic characteristic for erythroplakia could be desquamative gingivitis, erythematous lichen planus, discoid lupus, pemphigoid, hypersensitivity reactions. Infections could be erythematous candidosis or histoplasmosis. Haematomas or neoplasms are hemangiomas and Kaposi sarcoma. So this provides you with a list of differential diagnoses for oral lesions that appear as erythroplakia. So again, what we see here is a red velvety plaque that may be premalignant and may be the earliest sign of OMSCC in this high-risk site. But the diagnostic dilemma with regard to the diagnosis of oral epithelial dysplasia is that determining whether a dysplastic lesion will progress to squamous cell carcinoma may, in the future, require molecular markers, and there's a lot of research that's been done in this area. And some of these molecular markers may be the use of microarray technology. Numerous inflammatory related genes of the arachidonic acid metabolism pathway have altered expression in dysplasia, so that could be used. Loss of heterozygosity, especially at loci 3P and or 9P, increases the risk of progression of dysplasia to OSCC. Apoptosis and cell cycle alterations, and here apoptosis, which is natural cell death, decreases with one or more, with more severe dysplasia and OSCC. And obviously in squamous cell carcinoma you get uncontrolled growth, so the cell cycle, normal death cycle, is altered. Matrix metalloproteinases, MMPs, cytokeratin, which is a proliferative marker, as well as Chi markers. Integrins are also have been associated with malignant transformation of dysplastic and oral leukoplakia. So these are things that are currently available and may be developed further to give us a better diagnostic ability in the future. So here what you see is a dysplastic lesion and showing the oral epithelium with some inflammatory reaction in the connective tissue, and what you see here is various shapes and sizes of cells with hyperchromatism and haphazard arrangement, almost forming a droplet ready to invade into the deeper tissue. So oral epithelial dysplasia, again, management gives a clinical dilemma, because we know that not all dysplasias will turn into malignant lesions, and some can actually regress. So do we biopsy? Do we excise? But some of the management techniques involve surgery, including lasers, but there's lack of random controlled trials for evidence-based recommendation of this. Topical bleomycin and systemic cis-retinoic acid, there's no evidence to base recommendation of this treatment. Systemic leukopines may have some efficacy for short-term resolution of oral epithelial dysplasia, as seen in subcontinental populations. Attention should also be given to the diagnostic usefulness of toluidine blue application, which has been recently been shown to be good in the application clinically. Toluidine blue may also be useful in application for PVL or peripheral verrucous leukoplakia, where it's difficult to know which area should be biopsied. And what toluidine blue does is basically it stains areas of high proliferation, which tends to occur in dysplasia and MSCC, and therefore we know that that areas should be biopsied and or surgically removed. If we look at oral lichen planus and lichenoid lesions, oral lichen planus is a chronic systemic disease of established immune-mediated pathogenesis, mainly involving T lymphocytes. Disease commonly affects oral mucosa up to 2%. Skin, genital areas, scalp and nails may also be affected. Age range is 30 to 60 years, mainly females. Usually it's a bilateral presentation with symmetrical distribution. You may get white papules which may become reticular or plaque-like, or an annular pattern, or a desquamate of gingivitis as seen in this this clinical photograph. Histopathologically, what you get is a keratinized surface epithelium with basal cell degeneration. You can see that these basal cells are becoming disorganized, and there's a band of lymphocytic, mainly T lymphocyte, infiltrate at the basement, below the basement membrane. Immunofluorescence will also show fibrinogen deposited along the basement membrane zone. On the skin it may appear this way, where you get itchy papules, purple papules, which when you scratch may also give branching like tree branches called leukostriae. Diagnosis can be made on clinical grounds, but if the features are not typical, then biopsy is mandatory. In my clinical practice, I tend to biopsy because then you can get a 100% definitive diagnosis. Lichenoid dysplasia is a term for a lesion with pre-malignant process with features resembling OLP, not lichen planus with dysplastic features. So really the term dysplasia here is the important part. It's a dysplastic lesion that happens to have lichenoid appearance clinically. Other lesions that resemble oral lichen planus, oral lichenoid contact lesion. These are immune-mediated hypersensitivity reactions to dental materials such as amalgam and also cinnamon. Oral lichenoid drug reactions. These are lichenoid reactions caused by hyperglycemic agents and other medications such as ACE inhibitors and non-steroidal anti-inflammatory drugs. Oral lichenoid lesions also can occur in graft versus host. Acute graft versus host occurs within 100 days of grafting, and chronic occurs after 100 days transplant. And these are the clinical features that, or clinical appearances that you can get in lichen planus. In comparison, lupus erythematosus, which is suggested to be usually unilateral but can be bilateral, may give a very similar clinical appearance. And treatment of oral lichen planus or lichenoid lesions involves, where there's symptoms, topical corticosteroids. If it involves skin and other areas as well, sometimes systemic corticosteroids may be given. Retinoids have shown some efficacy. Calcineurin inhibitors such as cyclosporin and tacrolimus can be used topically or systemically. Tacrolimus has been linked with carcinogenic activity as well, so therefore has had some bad press of late. Others include azathioprine, mycophenolate morphitel, and so on. So this slide indicates some of the evidence base for the use of these same materials that have just been listed previously. So oral lichenoid contact lesions is a topographic relationship to suspected causative agent is amalgam, but there's no clinical or histopathological features to distinguish between an oral lichenoid drug reaction and plain lichen planus. And major, in graft versus host disease, the major complication of allogeneic hematopoietic stem cell bone marrow transplant, as mentioned, acute, affects 3 specific organ sites, skin, liver and gastrointestinal tract, including the oral cavity, and often managed with systemic steroids. Chronic, great number of organs involved, example salivary glands, and topical steroids and other include dexamethasone, mouth rinse, or topical tacrolimus. Oral lichenoid contact lesion histological confirmation is recommended, especially if clinically atypical, to exclude dysplasia and or malignancy. Skin patch testing of materials and any to be used as a substitute may be useful, but these are often difficult to arrange. Treatment may involve removal and or replacing or coverage of the possible cause of restoration, but you need to be aware that if you're replacing a perfectly good restoration, that what you replace it with is going to work just as well. Diagnosis may be difficult because lack of specific clinical and or histopathological features to distinguish lichenoid lesions from oral lichen planus. As I said, it may be hazardous also to replace an offending medication because the patient is on medication for other systemic problems. It may take several months for clinical change to be observed. With graft versus host, histological confirmation is required, especially in the absence of organ or systemic involvement. First line treatment might be topical steroids, second line topical calcineurin inhibitors, tacrolimus and primacolimus may perform better than cyclosporin. UV light radiation, PUVA, is not recommended in this situation. Lupus erythematosus, immunologically mediated inflammatory condition that causes multi-organ change. 2 types, discoid lupus and systemic. Lesions frequently appear lichenoid and may represent or resemble leukoplakia or vesicular bullous or granulomatous lesions. Systemic lupus will show anti-DNA antibodies in serology. Immunofluorescence will be required at biopsy to show deposition of various immunoglobulins and C3, complement 3 in a granular band involving basement membrane zone, seen also in uninvolved skin, called lupus band test. This is not seen in discoid. And again, the examples of clinical photographs. Carcinoma in situ is top to bottom epithelial cytological changes, characteristic of malignancy, but no connective tissue invasion. The distinction between severe dysplasia and carcinoma in situ is arbitrary, because severe dysplasia is also full thickness epithelial dysplastic change. Erythroplakic lesions more often show dysplasia or carcinoma in situ than leukoplakia. Again, here are some examples of carcinoma in situ. Again, more examples of carcinoma in situ. And histopathologically, you can see that the dysplastic change is bizarre change all the way through the thickness of the epithelium to the underlying connective tissue. Oral mucosal squamous cell carcinoma. If we look at verrucous carcinoma is a well differentiated malignancy. Microscopic diagnosis may not be obvious, but the basement membrane often intact, no obvious anaplasia, proliferates on a broad front. It proliferates on a broad front. One must be careful to evaluate multiple sections of an adequate tissue sample to render a proper diagnosis. It can mimic other conditions such as squamous papilloma or pseudoepitheliomatous hyperplasia. or oral florid papillomatosis. This is what the clinical picture may be of a verrucous carcinoma, and again, as you would expect, there's a large keratin layer with dysplasia and these broad-based rete ridges. Oral mucosal squamous cell carcinoma, there are 30,000 new cases of oral cancer each year. It includes lip, tongue, floor of the mouth, salivary glands, and pharynx. 7% of new US cancer cases and occurs 6.2% in males, 1.9% in females. But in Asia, it's 50% of all malignancies. So in different parts of the world, the incidence is different. Less than 30% of all oral cancers cases are cured, and up to 90% cure rates if it is discovered early. So the key here is that when you are examining your patients on a regular basis, we need to try and pick these lesions up early. Anyone can diagnose a frank carcinoma that has been long-standing. Cigarette smoking is considered to be a major cause of oral cancers. Pipe and cigar smoking increases the risk at the same rate as cigarettes. Smokeless tobacco puts patient at minimal risk regardless of reported studies. Relationship to cancer induction not as strong with alcohol as to tobacco. Heavy users are often also heavy smokers. However, how alcohol produces cancer is poorly understood. Is it a carcinogenic agent? Is it a solvent for other carcinogens? Does it increase exposure to oxidants? Does it suppress the immune system, especially locally? Actinic radiation, sunlight, plays a role in causing cancer of the lip vermilion. Skin pigment also seems important. Actinic cancers are higher in those with fair skin. Actinic cancers lower in those with dark skin, so melanin may play a protective role. Nutrition. Nutritional deficiencies or excesses have been linked to various cancers elsewhere, example in the colon. Iron deficiency has been linked to oropharyngeal carcinoma in Plummer-Vinson syndrome. Some evidence that fruit consumption is also protective against oral cancer. These include vitamin A, B, C, and E. Oral, dental, and occupational factors. No evidence that trauma from dentures, poor oral hygiene, or defective restorations, and so on, can promote oral cancer. Animal studies do show that trauma plus carcinogens causes cancer more readily than no trauma, but this at this stage has not been transferable to humans. Oncogenes, growth factors, and suppressor genes have been implicated, and some of these include HRAS, CMYC, CERB, B1, and so on, which, whether they are turned on and off, may be implicated in the progression of cancer. Viruses, especially HPV and HSV, may be synergistic in oral mucosal squamous cell carcinoma. Epstein-Barr virus and cytomegalovirus have been demonstrated in lesions of OMSCC. HPV antigen and gene products have been detected in biopsies of oral mucosal squamous cell carcinoma, and HPV's human papillomavirus also identified in metastatic lesions. Immune competence may also play a part here in reducing the defense against cancerous change. Clinically, OMSCC may have varied presentation of red, white, or ulcerated, raised rolled edges, tumour masses. If bone involvement, you may get irregular radiolucency. So clinically, these may be some of the appearance of oral squamous cell carcinoma, but again, a biopsies need to confirm the diagnosis. So cervical lymph node metastasis, angiolymphatic invasion, and perineal invasion indicates a grave prognosis for the patients. Tumour margins, where there's no tumour margins, if there's tumour in the margin, then there's an 80% recurrence rate. whereas compared to no tumour in the margins. Biological markers may be used to evaluate margins for tumour cells such as P53, HPV markers and P16. So histopathologically what you get is invasion of the underlying connective tissue, islands of epithelium, keratin pearls deeper in the tissue, and other features of dysplasia, an inflammatory defense reaction as well. Histological features of dysplasia include nuclear hyperchromatism, increased nuclear to cytoplasmic ratio, mitosis in prickle cell layer, abnormal mitoses, loss of polarity of the basal cells, keratinization of cells deeper in the layers, loss of definition between basal and prickle cell layers, diminished intracellular adherence, and those drop-shaped leaky ridges which are about to drop off and invade. Carcinoma will show these features as well, but also invasion of the underlying tissue. Keratin whorls also may occur in carcinoma compared to dysplasia. Metastatic tumours. Metastases into the oral cavity is an infrequent finding, approximately 1% of oral neoplasms. Lung and breast are the most common primary sites. Other sites that metastasis can include are from the kidney, thyroid, prostate, liver, testes and bladder. And usually it metastases to the jaws are more common than to the oral soft tissues. Gingiva and tongue are most common soft tissue sites. Thank you very much.